I'm Vance Fuller. Rules of difficult airway. Let's get started. Alright, the failed airway exists when any of the following are met. Failure to maintain acceptable O2 saturation during one or more failed laryngoscope attempts, or number 2, 3 failed attempts at orotracheal intubation by an experienced intubator, even when oxygen sats can be maintained, or, third one, the single best attempt at intubation fails in the forced 2-act situation. Okay, so the failed airway presents itself in 2 ways. Number 1, can't intubate, can't oxygenate. Can't intubate, can't oxygenate. There is not sufficient time to evaluate or attempt a series of rescue options, and the airway must be secured immediately because of the inability to maintain oxygenation by bag valve mask or with an extraglottic device such as your LMA, your iGel, your King. iGels are getting big now. The failed airway can't intubate, can oxygenate. There is time to evaluate and execute various options because the patient is oxygenated. At this point, we can stop sweating over the patient, okay? We can take a breather and come up with a plan, all right? Be smart about this. Use your assessment tools here. So, something to know, little extra bonus. The pulse ox can have a lag time of up to 7 minutes. This has been shown in numerous studies. Who's going to have a lag time of up to 7 minutes? Well, I'll tell you what, who? Those patients on Levophed, epinephrine drips, those patients with peripherally constricted arms, legs, wherever we're putting that pulse ox, it's going to show an increased lag time, or just going to be completely inaccurate. An obese patient, after pre-oxygenating, can desaturate below 85% in 3 minutes, where a healthy patient can last up to 8 minutes. Let's look at this chart here. Obese, 127 kilograms, desats below 90, right between almost 3 minutes, where a normal 70 kilogram patient desats below 90, right around 8 minutes. So, your normal 10 kilogram children desat very quickly. Moderately ill, why do they desat so fast? Well, because they have a huge oxygen demand. Alright, know the word before you go. Grab the map. Assessment keeps you in the know. So, lemon, our mnemonic for difficult direct laryngoscopy. L, look externally. Prominent incisors, excessive overjet, also known as Dracula teeth. Evaluate, 3-3-2, using the patient's hand. And that 3-3-2 rule, can you put the patient's 3 fingers in their mouth? If you do 3 fingers from hyoid bone to chin, and 2 fingers from Adam's apple to the top of the hyoid bone there. Malampati, 1, 2, 3, 4. 4, expect a difficult airway. 3, it may be difficult. 2 and 1 shouldn't have an issue. Obstruction, obesity. N, neck mobility, arthritis, or in the C collar. If that little lady has arthritis and can't move her neck, you're going to have difficulty getting her in that sniffing position. You don't need to necessarily hyperextend them, but if the neck doesn't move, it'll make it a problem getting those 3 axes lined up to intubate. Moans, difficult bag valve mask. M, mask seal, does he have a beard? Is there some different anatomy due to genetics or whatnot? O, obstruction, obesity. A, aged. Is that skin not as luxurious and pleasantly sealing than they were when they were 25? And no teeth. I tell you what, if they have false teeth in, leave those teeth in. That creates a platform to bag on. If you take those out prematurely, take them out if you want to intubate, absolutely, that'd be great. If not, leave them in. Stiff, your stiff lungers, your prego patients, asthmatics, they need a higher pressure evidently. Rods, difficult extraglottic device. R, restricted mouth opening. If their mouth isn't open, you're not going to get in those iGels, LMAs, or King airways in. O, obstruction, obesity. D, distorted or disrupted airway. If you got a 12-gauge shotgun blast to the airway or to the face, there's nothing that's going to be holding those devices in. Stiff, again, your tight lungs. Smart mnemonic for difficult Craig. Have they had recent surgery? Is that anatomy difficult to assess? So M for mass. They have a mass there. We don't know what it is. You're not going to be able to palpate that cricothyroid membrane. The anatomy, that kind of also relates to, are we going to be able to palpate that anatomy due to they have distorted anatomy? R, radiation. That skin gets very taut like leather, and a lot of that tissue shrinks, and your landmarks will be off as well. Tumor. T, is that a fatty tumor? Is it a vascular tumor? Those are things that we don't want to really go down that road. You need to control the situation. Don't let the situation control you. Your primary goal is gas exchange. If you don't have that, you have death. The difficult airway is something you predict. The failed airway is something you manage. All right, reasons to intubate. We predict it. We predict that their course of treatment or that their course of illness is going to be going down the drain and they're going to end up needing intubated. Protection. If they're risk for aspiration, if their GCS is under 8, those are other things to consider. What we don't talk about anymore is if they have a gag reflex. What we talk about is if they can swallow. There's people out there that are walking around today, right now, walking down the street that have no gag reflex. Congratulations, you have no gag reflex. But can you swallow? It's if you cannot swallow is where you're not going to be able to protect your airway. That's the true modern indicator of if they can protect their own airway. Oxygenation. Ventilation. Cannot do the exchange of gases. If they cannot ventilate, they cannot live. They cannot ventilate, they cannot oxygenate. Attempts are harmful intubations. So look at this. First attempt, you have a 15% chance of either having a tooth trauma, which that's the least of my worries, bronchospasm, esophageal tube aspiration. At attempt number 2, that goes to 48%. Attempt number 3, 71%. Fourth attempt, 87%. Make it count your first time. Propofol is the semen of the devil, according to Dr. Cliff Reed. He's a resuscitationist out of Australia. And propofol is bad for the HEMS environment on the helicopter. And here's why. This is my opinion. It numbs your baroreceptors. It lowers your systemic vascular resistance. And what we happen to do, a lot of times incorrectly, is we take off with these patients and we adjust their propofol. We titrate it up because we see them moving. And then what happens is we go on level flight, not as stimulating to them, and then their pressure drops. It's just overall great drug for ICU, not a great drug for helicopter service or airplanes. Helicopter or airplanes. Just too much stimulation, too much noise, too much vibration. Look up Dr. Cliff Reed's podcast. Very brilliant man, very passionate. Failure to evaluate the airway and predict the airway is the #1 cause of failed airways. Does that make sense? Also, bag your own patient. Predict it. You need to feel it. After you intubate, don't let the RT or whoever put it on the vent. Bag them 1 or 2 times first. Say, no, I'm sorry, respiratory therapist, I just want to feel the compliance. Because what's going to happen is, if you have an issue, high pressure alarm, on the way to the hospital, and you take them off the vent thinking something's going on, by bagging them, you can actually assess them. What was their baseline? How was the compliance the first time? How was the compliance when you took them off the vent and you bagged them the way you did the first time? Is it different? There you go. There's an assessment. There's something going on. Poor compliance, what'd you do? You might have popped a lung. Think of that. My patient was anterior. 4% of patients are truly anterior. That was in more than one study. EMS reports 30%. Well, I think that's because we need to learn more about the airway. There's some people out there that want to take intubations away from paramedics, and that's absolutely ridiculous. Ramping. There's no reason we need to lay a patient down unless they are hypotensive. If they are, we can give them a squirt of neosynephrine, 0.5 to 1 mics per kilo. That'd be fine if you have that in your drug box. We can bolus them. We can get that blood pressure up. Or we're going to lay them flat if they're spinal precautions. If not, why are we laying them flat? If they're obese, pregnant, we should sit them up. Let me put 50 to 85 pounds on your lungs and see how you breathe. You're going to saturate quickly. Be creative. Key signs of airway obstruction. I got a hot potato voice. Kind of sounds like that. That's going to be something with your epiglottitis patients, with your burn patients. Because if they have stridor, that's 1% of their airways open. Also anaphylaxis, may have stridor. Difficulty swallowing. Asthmatics retain air. What is a simple solution? Well, how do we lower the IU ratio on the vent? Instead of getting in there and actually manipulating the IU ratio, well, you drop the respiratory rate. By dropping the respiratory rate, you drop the IU ratio so they have prolonged expiratory time. If they still have high pressure alarms going on, take them off the circuit. They're probably going to be paralyzed for this or deeply sedated to do this, and push on their chest and let that air come out. Put them back on the vent. You've just burped them. All right, know your real estate. If you're going in there and you're doing intubation, you see a corniculate cartilage or the cuneiform cartilage, well, you kind of generally know that you're not far off. Left medial or right medial. Over on this side with your piriform fossa, that's a very common place that your extraglottic devices can go, specifically your king airway, and bounce back. Know where that area is and know your proper placement of those devices as well. And that is all. Thank you very much.